Okay, welcome everyone to our cardiac CT and MRI lecture series. Thank you for being back here. Y gracias por estar acá en nuestras series de tomografía computada de corazón y de resonancia cardíaca. Today we're going to have Joao Cavalcante talk about use of MRI for mitral regurgitation and what can it add. I want everyone to think how many MRIs you've ordered for mitral regurgitation, and then we can consider if this lecture will actually change your mind and you may consider it using it more. Just as a brief introduction, Joao is originally from Brazil. He did his med school in Fortaleza, Brazil. And then after that, he went to Detroit. So a little bit of a difference in climate, where he did his medical residency and cardiology training. He was the chief resident there. And then he went to another cold place, and he went to Cleveland Clinic, where he did his advanced training in cardiac imaging for 2 years. Now he's the director of cardiac MRI and structural CT at Minneapolis Heart, and he had an amazing career for his short age. He has over 250 publications. He participated in the writing committee for the new boards of cardiac MRI. He leads the SCMR valvular heart disease working group, and he's now a new member of the board of directors of SCCT. He's also a new associated editor for the European Heart Journal, and he's an editor for Brazilian Archives of Cardiology and an editorial consultant for JACC. So thank you, Joao, very much for being here. And I think I'm very looking forward for this lecture, and I think it's going to be great. So go ahead.
Muchísimas gracias, Leandro, a todos que están acá. Es un placer inmenso de poder hablar un poco de portuñol and speak to all of you today, hopefully in English, because my Spanglish or my Portuguese with the Spanish is not that great, but I look forward to also the discussion at the end and hopefully provide you some insights of how cardiac MRI could help in the evaluation of patients of mitral regurgitation. And just for the sake of this also talk today, highlight that our core lab, which I don't get any personal remuneration for that, also has other works in progress with many of the other device companies. So I thought about breaking it down into three main questions for the next 40 minutes or so about how cardiac MRI could be helpful. The first is to assess, does this patient have severe mitral regurgitation, particularly for the use in primary mitral regurgitation, degenerative mitral disease? And then talk about a little bit arrhythmogenic mitral valve prolapse phenotype, which has emerged more recently as an important marker that cardiac MRI could be of help. And then to finalize into this whole conundrum about the use of cardiac MRI in the evaluation of patients with functional mitral regurgitation. So when we talk about mitral regurgitation, important to obviously go back to the guidelines to understand who should be the patients we need to consider for surgery. On the left side, we have primary mitral regurgitation, degenerative. The patient has to have severe MR, defined by all these criteria by echocardiography and presence of left ventricular dilation. If they're asymptomatic, that's the only guidelines that said you should consider doing mitral valve intervention, particularly if the success of mitral valve repair is high in your institution. If the patients are obviously symptomatic, that's much more straightforward. But in the presence of left ventricular dysfunction, then obviously that should be, even if they are asymptomatic, but they have LV dysfunction, they should proceed. Now, if there is secondary MR, as we will hear, up to now, we should not consider or consider with some reservation the intervention of mitral valve surgery in the presence of symptoms and LV dysfunction, particularly after persistency after medical therapy. But now the use of MitraClip has obviously opened up the paradigm of treatment, as we will talk about. So what defines severe mitral regurgitation by echo? You have the quantification by PISA, 2D PISA, the use of regurgitant volume or regurgitant fraction. As you can see, there's mild, moderate to severe. And sometimes we don't have the capability to do this accurate quantification, as we will talk about. And the PISA, even though is the most commonly used method, you can derive the EROA, or the effective regurgitant orifice area. And if you multiply by the velocity time integral, you would get the regurgitant volume. But sometimes there are several discrepancies because there is a tendency to overestimation of the mitral regurgitation. as we assume that that regurgitant orifice area remains constant throughout the entire cardiac cycle, which is not the case. And when we look at how we do onto the echocardiography for the quantification of mitral regurgitation, it is pretty much scattered. So this is an important work by the group from Cedars-Sinai from a few years ago, looking at 16 patients that were interpreted at several institutions by 18 expert cardiologists at 11 institutions, and mitral regurgitation classified as severe versus non-severe using either vena contracta or PISA led to a very fair, to say almost horrible, kappa agreement. So that's less than a flip of a coin. And that's looking at both jet area, vena contracta, or EROA. So EROA perhaps a slightly more substantial agreement. But when you take, even within the same institution, let's say, okay, we're not going to go for all sites, but let's just look at the same site and see how that site would agree, it does not improve. It does not get better. So single center versus multi-center, EROA perhaps has a slightly better, but we're still at less than 50% of agreement of how to classify these patients in the present, whether they have severe MR or not. And why is that? Well, because small measurement errors, small measurements can have huge errors. So here's the same frame, almost the same frame, but we just did a small change in the measurement of the ROA from the radius here, change from 0.7 to 0.8. That would change substantially of how we classify to this patient to call now mild, this patient should not have mild mitral regurgitation. And what we're trying to define is actually, and this slide is from Dr. Paul Grayburn, who has done a lot of work on mitral regurgitation. And he emphasizes how difficult it is to assess severity of mitral regurgitation, because at the end, we're trying to define who has severe MR versus mild MR, to a difference between a number 2 pencil versus an oral thermometer. We're trying to see, in our measurement is not so precise. Then I put this bullseye plot just to show that perhaps we don't want it to be so accurate, but we want it to be reproducible. Ideally, we would like to be on the left side here, in which we are accurate to hit the bullseye, and we are very reproducible. Here we have reproducibility, but not accuracy, right? But here, perhaps is sometimes how echo, in the difficulty to acquire that, here we have no accuracy and no reproducibility. So it's all over the place. And with that, we cannot be consistent. We want it to be at least here in the middle, in which we have some reproducibility, but not so much substantial accuracy, but perhaps even more accuracy would be important. So when should we consider cardiac MRI? On the far right here, we have a nice review paper by Dr. Seth Uretsky from Morristown, who has done a lot of important work, particularly for primary mitral regurgitation, showing that MRI should be considered whenever we have the need for greater diagnostic certainty. So trying to see, are we there close to the bullseye? Especially when there is discrepancy between what we see and how the patients feel, especially in secondary MR to assess also viability scar, or whenever we have suboptimal images. And that becomes important in lots of these patients when we have a difficulty to ascertain, is this severe or not severe? And also I wanted to debunk some myths. We could say, oh, okay, let's do MRI, but it's expensive. It's much more expensive than echo. Well, the reimbursements from last year, you can see that echo without contrast is more expensive than MRI with contrast. And if you need to use Optizon or Sonoview or any of these other agents, Definity, you can see that actually is almost as double the price of the cardiac MRI. You can say, well, it's not available everywhere. And I would take that back, but we're trying as a society to say that whatever you could do your cardiac MRI could be a place where you can do also your knee MRI or your brain MRI. You know, why can't you do cardiac there? Yes, it requires software, it requires training, but the industry needs to also catch up. You could say, well, I cannot do this in patients that have implantable devices, or pacemakers, ICDs. Well, that has actually changed, and we need to update the community for that. And you could say, well, the information is not actionable. It's fun to do. It's, you know, perhaps an academic exercise, but that's not so true, as we'll see. These are just examples from our lab of patients that have, in this case here, an ICD. And you can see that, yes, if you use the standard SSFP or the standard state free precession, which is the method that we utilize, there was going to be some artifact, but one can still do the tracing. This patient that has both mitral regurgitation as well as tricuspid regurgitation. And when you put these patients in the cardiac MRI, you would see, images like that. In this case here, a P2 flail, significant mitral regurg, or in the case of secondary MR with severely dilated ventricle with the scarred ventricle, retraction and restriction of the posterior leaflet motion, that would be important. If we do cardiac MR, how do we going to quantify? And I'm going to be emphasizing the indirect method, which is the most commonly used. We need to answer two questions, which is how much MR do they have? And what is the forward stroke volume? So first, what is the LV stroke volume? It's how much was the end diastole and systole. That's what should have left through the aortic valve. In case of mitral regurgitation, a percent of this is going to be regurgitating back to the left atrium. So let's take, for example, this case. Here we have a bad cardiomyopathy. It's a severely dilated left ventricle, 350 mLs, and systolic volume of 263. You should have an LV stroke volume of 86 is what should have left through the aortic valve. But you see that this is not all the case because we already see the mitral regurgitation here and the poor ejection fraction of 25%. So 86 is what should have left, but when we do the through plane phase contrast, only 46 is what had left, right? So you do a simple math, 86 minus 46, you have a mitral regurgitant volume of 40 mLs. And if you have 40 mLs divided by the LV stroke volume, you have the mitral regurgitant fraction of 46%. And you could say, well, 40 mLs is not a whole lot, but look at the denominator, and that's what the importance is for the LV stroke volume for the denominator for the calculation of mitral regurgitant fraction. Because 40 mLs for this ventricle is a lot. 40 mLs for a ventricle that pumps 120, that's not too bad. So it's all relative. And echo, unfortunately, cannot give you with accuracy the calculation of mitral regurgitant volume, or even less so, regurgitant fraction. Does that matter? And it does. This is work from Saul Meyerson, looking at 3 centers in UK, 1 in New Zealand, looking at the quantification in patients with primary mitral regurgitation, was able to stratify those asymptomatic patients that were at risk for need for valve surgery or development of symptoms. And regurgitant volume or regurgitant fraction stratify much better than the EROA, and as well as the left ventricular volumes. And you can see that those that underwent surgical intervention had much greater regurgitant volume than those that were followed conservatively, as opposed to echo regurgitant volume, that there was no difference in the ROA or no difference into the echo regurgitant volume. Just showing that imprecision and saying how much more echo tends to overestimate compared to cardiac MRI. Take this another publication now, almost 3 years ago, 258 patients that from Czech Republic, looking at the agreement between MRI and echo for patients that had late systolic, so primary valve disease, eccentric, multiple jets. There was moderate agreement. In those that had a much more holosystolic central, there was very good agreement, looking at 2D PISA versus cardiac MRI. And in these graphs, what it shows is that the remodeling and the outcomes are driven by what cardiac MRI says, not by the severity by echo. For example, indication for mitral valve surgery, the combined all-cause mortality and surgery. Here, echo calls severe, so dashed black. Echo calls severe, MRI called moderate. These patients were not too bad, as opposed to when echo called moderate, but MRI called severe, this was as bad as when they both agreed that this was severe. So the outcomes were dictated by MRI severity, not by echo severity, as well as the remodeling. When MRI called severe, but echo called moderate, these ventricles were much more dilated than when it was the other way around. And the regurgitant volume, again, in primary mitral regurgitation, was much more dictated by the regurgitant volume by cardiac MRI. Again, another publication from Seth showing that comparing MRI versus echo, that echo tended to overcall MRI, overcall mitral regurgitation. So 56% of these patients were considered to have severe MR. When they were imaged by MRI, only 15%. And importantly, in the subgroup of patients that had received MRI after mitral valve intervention, they saw that the shrinkage, the left ventricular reverse remodeling, was much more consistent or much more correlated much better with the decrease in left ventricular reverse remodeling by MRI than by echo. And this is another recent publication by their group with also Houston, showing that this correlation, we can anticipate how much these ventricles will shrink in the absence of obviously scar after you have corrected the mitral valve, as you can see here, the pre and the post. In the post scenario too, the evaluation of patients with mitral clip can become challenging by echo, as we know. These patients obviously will have artifacts and they might have arrhythmias. So you need to adapt your sequence according to that, sometimes using gradient recall echo to minimize in the presence of also arrhythmia and also devices. And this is a small project that will only use 16 patients from Australia, looking at the correlation and the Pearson precision by the amount of regurgitation after clip had a much better correlation with MRI, looking at interobserver reproducibility than that interobserver reproducibility that we saw by echo. That was very poor. Okay, now switching gears to the arrhythmogenic mitral valve phenotype, mitral valve prolapse. This is just a quick synopsis of a 66-year-old patient that I had the chance back in Pittsburgh to see with a near syncope. He had sustained VTAC. He was shocked and went to the cath lab with normal coronaries, and then the echo showed the mitral valve prolapse, as you can see here, bileaflet prolapse, anterior and posterior with this mitral annular disjunction and this curling. And there was not substantial mitral regurgitation by echo or by MRI, but the presence of that disjunction was associated with the presence of myocardial fibrosis, this kind of non-ischemic mid-wall fibrosis, also involving the papillary muscles, which was responsible for his VT episode. And so this is another example here from our lab in Minneapolis, just showing, again, this mitral annular disjunction and prolapse. And when we do even the dark blood, we can see that nicely. And this same location, this patient had also not substantial mitral regurgitation, but they had PVCs and they had arrhythmia. So there's MVP and MVP, and this goes back to almost 34 years ago, actually 44 years ago, when this was first described. 34 years ago, when this was first described, showing that this floppy mitral valve prolapse, because of this significant billowing and up and down, can force some tugging of the papillary muscles, and that infralateral segment potentially being associated with the post-mortem findings of arrhythmias seen here at Johns Hopkins publication. And there's some emerging evidence that this fibrosis in biology might be important. This is one of the first publications that came, highlighting that by Cristina Basso from Padua in Italy, showing here the fibrosis in the basal infralateral wall, this mitral annular disjunction, and also fibrosis involving the papillary muscles. This is a publication from the group at Houston, showing that the greater the amount of mitral regurgitation, the higher the likelihood of fibrosis. They did not mention about the papillary muscle involvement, which is commonly seen, but in patients with MVP, the predilection for this kind of infralateral is the site, and perhaps the mitral regurgitation adding another insult into the fibrotic burden. And we're talking a lot about fibrosis, but MRI is an important methodology that assesses not only the amount of regurgitation, but also the capability to see scar. And scar has two faces, obviously, the ischemic scar, the non-ischemic scar, but this whole also interstitium, the ventricle, as it remodels, it will start to also expand the space between the myocytes, and collagen can be deposited. And as such, it will create, obviously, the perturbation of that. And here we have, two patients from our lab, similar ejection fraction, but one that has normal interstitium measured by this extracellular volume, and another patient that has an expansion of the interstitium with a higher ECV, or extracellular volume fraction. The concept of interstitial heart disease that we have been learning for aortic stenosis, it also can be translated into mitral regurgitation. And I found this publication, which is fascinating, 43 years ago, from Dr. Valentin Fuster, when he was at the Mayo Clinic here in Minneapolis, in Rochester. He looked at autopsy hearts, at 22 normal hearts and 20 hearts of patients that had undergone autopsy for extracardiac causes, and then 22 hearts that died early after mitral valve replacement with this kind of low output cardiogenic shock. And what he saw is that in patients that had this kind of mitral valve post-op low cardiac output syndrome, they had not only a stretched myocyte fiber, highlighting the importance of the substrate, the myocardial remodeling, but also a significant expansion of the interstitial space, to show that the ventricle also suffers from that. And obviously nowadays we have a much more elegant technology and technique to evaluate that, which is the use of the ECV and also LGE. Patient from our lab showing that asymptomatic but severe MR LV dilation, preserved ejection fraction, but again already ECV expansion. And this group from Manchester by Rick Steed, showing in asymptomatic patients, 35 asymptomatic patients, when they had increased ECV, there was similar ejection fraction, but greater ECV, but greater left atrium, right? The chamber that receives that amount of regurgitation, and already decreased the mitral annular plane systolic excursion that one can measure with tissue Doppler, or here, slightly depressed strain as well, and a correlation between ECV and the ejection fraction. So could this ECV be already a precursor of some incipient myocardial disease that occurs in these patients, even in the absence of myocardial fibrosis? Is something that we need to learn more for these patients and trying to improve the timing of intervention. And then to finalize, to talk about this conundrum of functional mitral regurgitation. I think everyone here remembers that 2 years ago, when we had the first results of the COAPT trial presented at TCT, it was really a game changer in terms of treatment of these patients with secondary mitral regurgitation. It took them 2 years and lots of patients, 614 patients that were randomized to goal-directed medical therapy or MitraClip plus goal-directed medical therapy. And what they saw was that those that were treated medically, and in addition to that, the mitral regurgitation was still significant. After they received the MitraClip, there was a substantial decrease in all-cause mortality and heart failure hospitalization. So a number needed to treat of only 4 patients to reduce one of these events. This was obviously sponsored by Abbott, and they had to have a very strict entry criteria, a very strict heart failure follow-up, as well as being optimized medically. 61% of these patients had ischemic cardiomyopathy. On the other hand, the MITRA-FR that was led by French investigators, this is the 1-year follow-up, but the 2-year that just got published a few months ago shows the same thing. There was no differences in these patients that were treated with the MitraClip. So now we have 2 cohorts, one that shows substantial benefit, the other one that does not show the benefit. Who is right? And that's the question that we wanted to see. Then some conceptual work by Dr. Paul Grayburn has been proposed to explain why these 2 trials have such different results and divergent results. This concept of proportional or disproportionate MR or non-severe MR, to show that patients in COAPT, they tended to have much greater mitral regurgitation assessed by EROA, but not substantial left ventricular dilation. So this was disproportionate severe MR, meaning that the mitral regurgitation is the main driver. And by doing that, we should have some improvement, not only their symptoms, but also in the outcomes. On the other hand, patients with the MITRA-FR had some mitral regurgitation, perhaps not so severe, or less severe than the COAPT patients, but mostly substantial left ventricular dilation. And this here, the ventricle was the main driver, with the coadjuvant here being the mitral regurgitation. And by fixing the mitral regurgitation, you might do some good, but perhaps not as much as in the COAPT. And obviously, as any Venn diagram, there's going to be some overlap. COAPT patients that look like mitral FR, and mitral FR patients that look like COAPT. However, this is all conceptual. There's no patient data. It uses a Gorlin equation with the fixed ejection fraction of 30% and a regurgitant fraction which is quite high of 50% for secondary MR, and lacks any clinical validation of patient data. And there have been a lot of questions about the validity of this model, and even if it is achievable using the data from the COAPT. So more recently, earlier this year, Dr. Grayburn has then tried to divide, and not using the EROA by LEDV, but actually a ratio of the EROA divided by the LVDV. So what does that mean is that if you have a higher ratio, that means that you would have a much greater, because the LVDV is going to be in the denominator, you're going to have a greater remodeling to the degree of EROA. So the far to the right, the worse it is. And as actually, I'll take it back. The far to the right, actually, the better, because your denominator is going to be actually greater, right? So when the LV is not going to be so dilated. So the far to the right, the better it is, as opposed to the far to the left, in which you're going to have a substantial greater LV remodeling to the degree of mitral regurgitation. So those are the mitral FR patients. And what he showed is that all the COAPT patients tended to be in much, greater proportion of EROA to the LVDV, perhaps. Then this group from Leiden has published, this is in press now at JACC Imaging, showing that this ratio of the regurgitant volume. So now we're not looking at EROA, we're looking at the regurgitant volume, which you can calculate from the EROA if you multiply by the VTI, divided by the EDV, again, showing that the greater this ratio, again, the further away, more mitral regurgitation you have, much more you should fix and lower the inclination here. But you can see that the spine does not change much and the separation is a bit weak. But when you look a little bit more in depth on the table 2 of that study, I am quite perplexed and I cannot wrap my head around, because they calculate this ratio of a regurgitant fraction by Doppler of 77%, with a regurgitant volume of 174, with a ventricle that had an EDV of 189. So that means that almost the entirety of the left ventricle end diastolic volume is occupied by this regurgitant volume. It doesn't make sense. And so I question actually some of these values that were obtained. And you can see that by PISA, the regurgitant volume is much different than what they measure by Doppler. So there is a lot of inconsistencies. And then this recent paper that is in press as well is questioning how can we try to be accurate with Doppler when we need so many assumptions. We assume that the mitral annulus is a circle when it's not. We have to measure the pulse wave Doppler not at the tips but at the mitral inflow. We have to also assume that the left ventricular outflow tract is a circle when it's not. We have to measure also at the proper distance, not too far in, not too far out. So, and then we cannot calculate left ventricular volumes well by 2D method. So it's all over the place, to make the long story short, and a lot of imprecisions, to say the least. And when the authors of Mitral FR, the French authors, are trying to evaluate this more recently, using several of these indices, regurgitant fraction when possible, EROA divided by EDV, or regurgitant volume, it doesn't matter which subgroup it is, there was no benefit of the clip. Even in those that look like COAPT, and trying to put that same graph, this is the star, this triangle, red triangle, that's when the EROA is high, but the ventricle is not so dilated, it crosses 1. So it doesn't matter, and perhaps it calls into question whether or not this is even achievable. So let's just take a step back. We have been talking a lot about remodeling, a lot about volumes. But I wanted to ask you a fundamental question, is that we say that in secondary MR, the problem is not the valve, the problem is the ventricle. But how do we assess ventricular health? Right? We look at ventricular dimensions, volumes, all of those are surrogates of remodeling or function, right? Ejection fraction or global longitudinal strain, but we're not driving it down to the substrate, and the substrate scar is an important determinant of these outcomes, as there is a significant interaction and interplay between all these three musketeers here. So that's the work that we were fortunate to have it published last year from the Cleveland Clinic, looking at this through the lens of cardiac MRI. We had a large cohort of patients. Everybody has ischemic cardiomyopathy. Everybody has from 1 to 3 vessel coronary artery disease. Patients that were advanced ischemic cardiomyopathy, mean ejection fraction of 25%. Everybody underwent cardiac MRI. So you will have a spectrum of, everybody has low EF, but you will have a spectrum of mitral regurgitation from patients with no MR to patients with significant MR. You're going to have also a spectrum of infarct, patients with no infarct or minimal infarct to patients that have a lot of infarct. So the myocardial infarct size was 24% of the LV mass, which is substantial as an average, and the average mitral regurgitation fraction was 18 plus or minus 17%. These patients had been well treated with lots of beta blockers, lots of ACE inhibitors, aldosterone blockade in 24%, which is similar to the GET with the guidelines heart failure registry. Median follow-up was 5 years, and lots of events. And the events here being either death or heart transplant. And in a multivariable analysis, both the amount of MR, ischemic MR severity, measured by regurgitant fraction, and the extent of myocardial infarct size were prognostically important. So let me take you through this graph. We can see that the scar of this patient, basal infralateral wall, and here we have the more mitral regurgitation the patient had, the worse the outcomes. You could say, well, this is the same as looking at PISA, EROA, but you can see here that the inflection starts to occur even at the lower percent of mitral regurgitant fraction. And mitral regurgitant fraction above 50%, which is what that model that I just described was trying to advocate, it's almost impossible or very infrequently seen by cardiac MRI. And you could think that the more scar one patient has, the more mitral regurgitation, the likelihood that they would have. And actually, there was no correlation between the infarct size or the amount of mitral regurgitation. However, there was a very strong interaction between the amount of MR and the amount of scar to the outcomes. Let me take you through. Here we have 4 classes of infarct, from patients that had no infarct to patients that had more infarct. If they don't have a lot of scar, if I increase the mitral regurgitation, the increase in the hazard, it goes up, but not substantially. On the other hand, for patients that had a lot of scar, a little bit of MR, it increases substantially the risk of this patient, showing that it behaves differently, the risk in the presence of scar. And we have to understand them together, not separate, or not saying that scar does not matter or ignore that. In fact, when we look at the entire cohort, in addition to important other covariates and adjustment for several other confounders, this two-way interaction, a lot of MR with a lot of scar, was really the worst player. Even in those that had mitral valve surgery, which is a subgroup of 120 patients that received CABG with mitral valve replacement, you can see on the yellow here, that's a lot of MR, but not substantial scar. Actually, these patients had a survival benefit. On the other hand, if they have a lot of MR and a lot of scar, it doesn't matter what is done. They might be better off to go for LVAD or transplant. And again, this is going through an invasive open heart surgery like mitral valve replacement or mitral valve repair. Could this threshold of scar be different now that we are going through mitral clip, right? Because it's a much more slick procedure that you can go in and get out without less insult, cardioplegia, RV dysfunction, et cetera, et cetera. That remains to be tested. But was very intrigued by also this great editorial by Dr. Blaise Carabello that wrote saying that, how could this data be applied to mitral FR and coapt? Majority of these patients had ischemic MR and making this applicable, but the scar burden was not measured. So we don't know, but future studies should consider the evaluation because it might inform us. And in fact, this is very timely to see also this report from coapt by Dr. Grayburn. And as I showed you, coapt is a landmark study, no doubt about it. But even in those that receive mitral clip after failing medical therapy, after failing CRT, and after having some benefit, 54% of them were either dead, had a heart failure hospitalization, or had no improvement in their KCC change. 54%, that's more than half of these patients. And that's not to say, oh, okay, it's because they had residual mitral regurgitation. Even in those that did not have residual mitral regurgitation, they were considered non-responders. So 54% of those receiving mitral clip were considered non-responders, to say we need to look beyond our current methodology to better select who are these patients in which we might consider to do other interventions or other modifications of that. And this is just a glimpse of what the future might look like. This publication from Velou and colleagues looking at a cardiac MRI before mitral clip, 22 patients. They just did a binary fibrosis, yes or no, by LGE. You can see that those that had fibrosis tended to have much more ischemic cardiomyopathy, more dilated ventricles, worse ejection fraction, as you would anticipate. But looking at the 1 month changes in their New York Heart Association class, the absence of fibrosis actually made them feel so significantly better, an improvement of the New York Heart Association class. But also the difference between these patients and the other group of patients that had myocardial fibrosis, in which there was almost like a lateral move. Despite receiving clip, there was no substantial change in their New York Heart Association, even death. And in 9 of those 13 patients that had fibrosis, there was an adverse outcome occur compared to only 1 in 9. To highlight that this is an important biological marker that makes sense, but not currently applied or utilized. Just take you to finalize a couple examples from our lab. A patient that had received 2 mitral clips. This has paused us to now think critically about these patients, and we're doing follow-up, and now we're doing prospectively the evaluation of these patients that had non-ischemic cardiomyopathy, received the mitral clip. Mitral regurgitation actually improved, but when you can see after the gadolinium is that there's this diffuse non-ischemic mid-wall ring-like appearance, and it was a genetic mutation of desmoplakin C mutation. Another patient that we scanned just a couple days ago, showing they had a large pleural effusion inpatient with mitral clip, rehospitalized for heart failure. And you can see this is a totally free breathing study with high res quality images. And you can see that he has a scar from a prior myocardial infarction, both in the LAD and RCA. He had prior CABG, but also he has this mid-wall non-ischemic fibrosis with elevation of his ECV. And no substantial mitral regurgitation, just to show that the problem is not so much the amount of reduction of MR, which is definitely important, but also the ventricular substrate that we are dealing with. And another case that we had here for a patient that had chronic total occlusion in the RCA and circumflex. You can see the ventricle is dilated and dysfunctional, is hibernating. And you can see on the delayed enhancement that there's not a whole lot of scar. You can see this even better with the dark blood on the arrows here, that the amount of scar is very minimal, but there's a lot of MR, not so much by volume, but regurgitant fraction, again, in this poor ventricle. And the plan is to do obviously PCI and see if we can improve this ventricular function. And if the mitral regurgitation persists, then obviously consider mitral clip. And just to show that the technology continues to evolve as well, again, there have been several myths to say, oh, we cannot do this in these patients because they cannot breath hold, the images become really bad. We need to obviously be in tune into what is going on so that we can provide the best free breathing technologies to enable the characterization, the quantification of scar. So in conclusions, ladies and gentlemen, echo, although the first imaging modality to quantify MR severity, is prone to errors and unfortunately not reproducible. The 2D PISA does not provide the mitral regurgitant fraction or accurate quantification and overestimation of mitral regurgitation. CMR has a growing complementary role and it is reproducible even in the presence of arrhythmias for both the quantification of MR and myocardial fibrosis, an important driver of the outcomes, as I have shown, particularly for the secondary MR. And further education initiatives and trials should consider integrating cardiac MRI to understand the interplay between the myopathy and the valve disease to improve patient selection and obviously patient outcomes. And with that, I would like to just put a plug for also, if you're interested in learning more about TMVR and mitral regurgitation and assessment for these patients, we will have our workshop, and this link you can find more information. Acknowledging also our work by the postdoc scholars in our core lab, our CMR lab, and our CT here in Minneapolis Heart Institute, and many other collaborators across the country and the world. Thank you very much again for this opportunity.
Thank you.
Thanks, Joe. That was outstanding. Amazing conference. I think we all learned a lot. So please put your questions in the Q&A and we will answer them one by one. And also at the end, we're going to have a case in Spanish for the Spanish-speaking people watching this lecture. I will start with two questions while we wait for questions from the audience. I think you made a great case for the utility and how much cardiac MRI can change the outcomes and the plan for therapy. So in primary mitral regurgitation, when patients are asymptomatic, do you think everyone should get an MRI if they have moderate or severe? Do you think we have a case that being so cheap and changing the outcomes and the plan so much, should everyone just get it?
I think if they are asymptomatic with severe mitral regurgitation and the ventricle is not dilated, I would pause. I would get some more information. It's not to say that these patients might not benefit from mitral valve intervention, but I believe that the characterization, it's going to be important in how much of that ventricle will shrink. In those that have moderate mitral regurgitation, there is also a role. That's not because I love cardiac MRI that everything is MRI. I think there is a role also for stress echo, right? I mean, the mitral regurgitation is a dynamic valve disease that sometimes you might elicit worsening of mitral regurgitation with exertion, pulmonary hypertension development. But I think, in the absence of symptoms in normal LV size, please, let's think about that first hard before we subject these patients as well and get more volumetric quantification.
Okay, great. And the other question, and then we'll go to the questions here, is you just brought TMVR. So what about planning of the intervention using MRI and the measurements? How do you deal with the measurements for interventions with MRI as compared to CT?
Yeah, so far right now, MRI does not have the same spatial resolution and software capabilities for doing that for TMVR planning. We can look at the MRI as a great tool, as I shown you before, to understand the left ventricular reverse remodeling. And one thing that we are starting to work on is in those patients that have borderline new LVOT measured by CT, could those patients be at risk not for immediate left ventricular outflow tract obstruction, but after you have fixed the MR, is this ventricle going to shrink and then cause a problem later down the road? Because the TMVR platforms to this date, they completely eliminate mitral regurgitation. So in the absence of scar, these ventricles should shrink and you might have a problem later down the road. And that is something that we are looking into, that's particularly for these patients with borderline. But for the MRI planning for TMVR, for mitral valve replacement strategies, not so much, although one could use the scar location to inform better patient selection, as I mentioned before, for patients that have already an apical scar or an apical aneurysm. Obviously, you wanted to stay away from that or do an aneurysmectomy for that planning, but not necessarily for the sizing as we do for CT.
Okay, great. So let's go now. There are some questions starting to come through. From Rashna Kataria, fantastic presentation. To what extent might 3D echo be able to match up to CMR or overcome limitations of 2D TT?
Rachna, this is a great question, and I agree wholeheartedly that 3D for the left side is important, even more so for the right side. And 3D does a great in terms of improving the accuracy of that. 3D vena contracta area also has been shown to be much better with better correlation with MRI. So yes, if you're going to do, please do. The problem is that access for 3D echo and training is also not widely available.
Great, thanks for that. So Edwin Ho, or imager for the interventional cases with a SIM, he's asking the same question: Can MRI be used for TMVR, TTVR sizing?
Mm-hmm.
I
Yeah.
guess.
So thanks, Edwin, for the question. Great to see you here. Remember some conversation we had back at the TVT a couple years ago. Yeah, we are doing for the tricuspid valve, since you put the TTVR, as you know, we're doing the Triluminate study right now, which takes into both CT and MRI. And it's been a great learning process for us to see the value that MRI can do for the quantification of baseline mitral or tricuspid regurgitation, for that matter, RV remodeling, and also even after intervention. It creates some artifacts, as you would anticipate, but actually with free breathing acquisitions, excellent results so far.
Okay, we have a question from Carlos Dumont. I think it's a great question and something that has shown to actually matter a lot, I think, in the measurement of the severity of regurgitation. So how to deal with background offset error?
Well, great question. A lot of the sources, first of all, is that I would, as much as possible, do first, phase contrast should be applied and should be used even if patients don't have valvular heart disease. I think one of the misconceptions, people say, oh, I don't know how to quantify, I don't know how it is, because I don't do routine. In fact, we do phase contrast in all patients. It could be a 23-year-old coming in for a query HCM. We do in all those patients that have sinus rhythm and nice ventricles to be traced is a great way to corroborate your tracing. So I would say do this in everybody so that you calibrate your tracings with what you measure by phase contrast. We include the papillary muscles into the left ventricular volume. We do not exclude them, putting the muscles into the left ventricular mass. So that's another whole 10, 15 minutes discussion. In regards to the background offset errors, we have softwares that are able to do that. And you can do the contour of either the pectoralis muscle or also of the air, the space there, and they calculate Siemens. And the other important thing too is to put the patient into the isocenter of the magnet. The further away, neither north or south, there might be some small eddy currencies and inconsistencies of your gradients that might change. It is not substantial. But the offset errors, if present, you can always do with and without background correction by doing the contour. And I use circle, for example, and you can do that easily.
Thank you for that. What about when you do, if you look at phase contrast, how do you deal with the through plane motion of the mitral valve? Do you think 4D imaging is a solution for that? Do you use it commonly, or?
Yeah, so you're talking about the direct measurement, and we tend not to use, Leandro, because of this exactly through plane. Especially in the mitral valve prolapse, right? It goes so much up and down that becomes quite challenging. There is some work in progress by 4D flow that would allow us to be able to track the motion, annular tracking. The problem is the acquisition and post-processing. So the indirect is the one that we have the largest experience to date.
Okay, any more questions? I think we don't have problems. So if someone is getting an MRI and they want to do a lot of imaging for mitral regurgitation, do you think they should get a 3T, or you think a 1.5T can image properly the valves?
1.5. The 3 Tesla might give you more headache than what you want because they're flow artifacts. 3T is great for knees, brains, meniscus, things that are very sharp in detail. And 3T is great for cardiac applications for stress, for example, where you need a lot of signal. but for the run-of-the-mill valvular heart disease, 1.5 is much better. You're going to have less background offset errors, less phase dephasing, shimming. You need much less, so it's much less headache and much cheaper for that matter.
Absolutely. Okay. Thank you.
Mm-hmm.
I think we can go to the case now by Javier Lopez that he's going to show. If you don't follow him on Twitter, you should. He has always amazing cases and his pictures have amazing quality. So he's going to present in Spanish for the Spanish-speaking crowd. So if you don't speak Spanish, I think we can finish there. If you want to watch the pictures, you can also stay.
Hola, ¿cómo están?
Hola, ¿cómo
están? Hello, everyone. Hello, everyone. Acá
Hola,
tenemos
Javier,
un
gracias
caso.
por...
Hola, muchas gracias por la invitación. Bueno, vamos a tratar de mostrar un caso aplicando básicamente la resonancia a un caso limítrofe, digamos, ¿no? Acá tenemos nuestro caso. ¿Qué aporta la resonancia cardíaca al estudio de la insuficiencia mitral? Nuestro paciente, médico, un problema ya, ¿no? Que sea médico el paciente. En clase funcional 1, ¿no? Se le hace un eco al paciente, el paciente no tiene ninguna otra enfermedad, another disease, y se ve que tiene una fracción de eyección normal, un ventrículo que no está dilatado, acá tenemos los diámetros sistólico-diastólicos, se describe un prolapso de la válvula mitral, grado 3, grado 4, grado de insuficiencia, y una presión sistólica de arteria pulmonar normal. Eso es nuestro eco first, en consonancia más o menos con Twitter, digamos, ¿no? 65 años nuestro paciente, y se le pidió una resonancia cardíaca porque vieron un par de conferencias que habíamos dado en Chile, y bueno, pensaron que podía ser un buen complemento de este paciente que, repito, es un paciente asintomático. Class 1, New York Heart Association. Tenía una ventana acústica regular, por lo cual los volúmenes ventriculares que se habían sacado no eran muy confiables. Acá tenemos el estudio de resonancia cardíaca, eje corto, 2 cámaras, 4 chambers, 3 chambers, y pueden ver perfectamente el signal void o el defecto de señal que se ve ahí. Tiene un prolapso de todos los velos, digamos, pero impresiona que tiene un flail de la valva posterior o posterior leaflet, ¿ok? Y acá ven el jet regurgitante. Seguimos avanzando. Vamos a ver un poco mejor la morfología de la válvula mitral, que es parte de lo que nos aporta la resonancia cardíaca. Veamos acá más lento, veamos la unión. Hacemos la medición y vemos que tiene más de 5 milímetros. O sea, el paciente tiene un MAD, digamos, ¿no? Annular dysfunction. Seguimos acá, ven ahí, un poquito mejor, con mejor resolución. Lo mismo para el velo posterior leaflet. Tenemos un flail del mismo, que también lo podemos ver. Y acá hacemos un corte de cine, donde vemos directamente un hueco, a hole, a nivel de P1, P2 prácticamente. Esto es lo que nos puede aportar desde el punto de vista morfológico. Yo considero que el eco 3D es mucho mejor para esto. Yo habitualmente lo hago, pero es un complemento muy importante que nos puede dar la resonancia cardíaca haciendo un solo estudio, ¿no? Tenemos que considerar que hacemos un solo estudio que nos aporta todo esto: anatomía, función, caracterización tisular. Y bueno, vamos a las mediciones. La típica planimetría que hacemos. Esto es muy importante hacerlo en forma muy acuciosa, sobre todo para calcular los volúmenes. Acá vemos los volúmenes, la masa. Muy importante para que haya reproductibilidad de esto, que el último corte, el corte basal, se incluya solamente los segmentos que tienen más del 50% de miocardio, para tener reproductibilidad y por otro lado para no incluir la aurícula izquierda y sobreestimar los volúmenes. Esos son los tips para la planimetría. Seguimos. ¿Incluimos los músculos papilares o no los excluimos? Incluimos. El stroke volume más cercano a la realidad es cuando tú incluyes los músculos papilares y baja un poquito el stroke volume. Cuando no los incluyes, aumenta la reproductibilidad del estudio, ¿ya? Porque cada vez que tú incluyes las trabéculas y los músculos papilares, empieza a haber fallas en la reproducción de entre un centro y otro, por lo cual habitualmente uno hace esta opción, ¿ok? Pero esto no está estandarizado, así que habitualmente hacemos esto, pero hay que tener en claro que el stroke volume más cercano por el método planimétrico es este. Otro tip: si el paciente tiene mucha arritmia o puede tolerar mar, obviamente vamos a tener estos ghosting o estos fantasmas que se ven acá, y esto nos va a impedir hacer una planimetría adecuada, y una forma buena para intentar reproducir la diferencia BDBI y los volúmenes latidos, stroke volume, es utilizar el cross-reference, plano a plano, ir chequeando que cada punto esté en relación. Habitualmente yo lo hago con el 4 cámaras esto, ¿ok? Pitfalls, intracardiac shunts. Esto sirve solamente cuando no tienes shunts intracardíacos, cuando no tienes otra insuficiencia concomitante, ya sea aórtica, tricuspidia o de la pulmonary regurgitation, ¿ok? Y bueno, vamos a empezar a ver qué nos aporta la resonancia cardíaca. Vemos que acá los diámetros están sumamente similares. Estos son 3 cámaras, al igual que como hacemos en el eco, igual que el eco first, pero miren los volúmenes. Los volúmenes están sumamente aumentados acá, y esto no lo podíamos ver, y esto ya nos habla de un grado de repercusión mucho mayor de esta insuficiencia mitral, que era en un paciente asintomático, pero sin embargo vemos que la resonancia nos aporta los volúmenes, y es el gold estándar para esto. Así que lo tenemos que tener muy presente. Seguimos para calcular el método, digamos, ¿no? El contraste de fase, siempre a nivel de la aorta, unión sinotubular, habitualmente lo usamos, y nos da 71 ml por bit. Recuerden lo que tenía antes. Hay unas potencias pitfalls, que son básicamente que tenga un ritmo muy irregular o que el paciente no tenga una adecuada capacidad de mantener las apneas, ¿ok? Vamos al método, entonces. Tenemos el método planimétrico, acá. Esto nos dio un stroke volume, que lo vamos a ver acá, 173 ml, por el Q-flow, a nivel o el phase contrast, tenemos 71 ml, y esto nos va a dar un volumen regurgitante de 112 ml y una fracción regurgitante del 58%, lo cual es severa, con una fracción de eyección normal y un paciente que está sintomático, digamos, ¿no? Esto es un problema básicamente para cuándo vamos a operar a este paciente. Un second check que hacemos, utilizando la diferencia BI-BD, vemos que la fracción de eyección es 66%, normal baja, y vemos que la diferencia BI-BD nos da 100 ml de volumen regurgitante y una fracción regurgitante del 57%. Esto lo comprobamos plano a plano, digamos, ¿no? Usando el eje corto y el 4 cámaras, y vemos que la fracción regurgitante por este método es también del 58%, o sea que en cierta forma chequeamos que por 2 métodos la fracción regurgitante y el volumen regurgitante son similares, ¿ok? YCBM, ¿qué más nos aporta la resonancia cardíaca? La caracterización tisular. En este caso, nosotros vimos que tenía el paciente una disfunción anular con un prolapso de todos los velos, digamos, y un flail de la valva posterior. Sin embargo, vemos que no existe realce tardío, lo cual es un marcador pronóstico de mortalidad en este caso, pero la resonancia nos permite ver eso en el mismo estudio. Y por último, la caracterización tisular. Nosotros tenemos unos valores más o menos de 950 a 1950 milisegundos de normalidad para el T1 MAPAM, esto es 1.5 Tesla, y en este paciente ya tiene 1089 milisegundos, esto está comprobado tanto en eje corto como en 4 cámaras, y tenemos ¿cómo se llama? Un volumen extracelular calculado en el límite, digamos, ¿no? 29%, o sea que estamos viendo que ya hay signos iniciales de fibrosis microscópica o fibrosis difusa o intersticial fibrosis, que son marcadores pronósticos que por otros métodos no los tenemos. Entonces, tenemos nuestro paciente que por el eco tiene una insuficiencia mitral grado 3, grado 4, con una fracción de eyección normal, y es un paciente asintomático. En este caso, ¿qué es lo que vamos a tener? Que, bueno, habitualmente no está tan clara la indicación de operar. Acá, en general, estos pacientes no se los opera. Entonces, yo pienso que hay que pensar en resonancia cardíaca porque, en este caso en particular, nos aporta otra serie de datos que no teníamos previamente. ¿Qué nos aportó? El paciente tiene un ventrículo izquierdo dilatado, con una fracción de eyección normal, y tenemos el método gold estándar de cuantificación de cavidades. Por otro lado, agregar el contraste de fase y por los diferentes métodos nos permite calcular el stroke volume, nos permite ver una caracterización tisular que, si bien el paciente no tenía fibrosis en la pared inferolateral wall, ya tenía signos de fibrosis inicial, y por último nos permite ver la morfología valvular. Entonces, siempre yo recuerdo esto, ¿no? ¿Cuál es el tiempo óptimo para la cirugía? Bueno, acá tenemos nuestro hombre corriendo, nuestro paciente en cuestión, pero vemos que todos los parámetros que habitualmente usamos en eco, la dilatación ventricular, el volumen del sistólico, son parámetros que aparecen cuando nuestro paciente empieza a tener una capacidad funcional baja y la sobrevida baja. Así que yo creo que hay que empezar a incorporar métodos que nos permitan tener mayor precisión para clasificar y mandar a operar a nuestros pacientes, ¿ok? Eso es, ¿qué nos aporta la resonancia? What can it add? ¿Qué piensa doctor Cavalcante? Muchas gracias.
Fantástico caso, ¿no? Este se fue impresionante cómo se ha hecho la explanación de la capacidad de cubrir todos los aspectos que estamos a discutir, ¿no? Y una bellísima explanación de cómo se la resonancia se le puede agregar un valor mayor, ¿no? En los pacientes, porque ha cambiado completamente los diagnósticos, la severidad, y también a mostrar la doença intersticial incipiente, ¿no? Que se está a empezar. Entonces, a mí me interesa saber mucho lo que se fue ese desarrollo de este paciente, ¿no? Desde que se fue a la discusión, porque, como ha dicho en lo comienzo, de que es un médico, ¿no? Entonces, con toda esa información, lo que se pasó con los pacientes en lo final.
No, bueno, era médico, obviamente le contamos al paciente lo que encontramos y planificó la cirugía y se operó.
Ah, sí.
Sí.
Sí,
Pero
qué
lo habitual es acá que la mayoría tomen como los cirujanos igual, toman los diámetros, de una fracción de eyección normal y el paciente está en clase funcional 1,
Sí.
salvo que sea un centro con una gran experiencia y pocas complicaciones, a los pacientes no los operan, digamos, ¿no? Esperan a que desarrolle los síntomas y por eso siempre muestro esta curva, digamos, ¿no? Esta curva que básicamente te muestra que la sobrevida empeora al momento que usamos los parámetros habituales para indicar operar un paciente en clase 1, digamos, ¿ok?
Sí. Yeah, I think they're asking us to switch back to English here for the discussion, but I was just congratulating Javier for the beautiful case and explanation that really covers very well all the topics that we had discussed, and how CMR can really add value to the evaluation of this patient, because the diagnosis has completely changed. And I was asking him, what ended up happening to the patient, who happens to be a physician as well. And the patient ended up going to mitral valve surgery, correctly so, because the ventricle is already quite dilated. The indexed LVDV, it's probably going to be in the 120 something, right? Because it's 264 or something, the end diastolic volume, right? I mean, it's a substantial left ventricular dilation.
I think, what do you think, Joe? I think also it's very important to how we label the patient, because many times with echo, we have patients that are labeled moderate to severe, and it makes a big difference even for follow-up. If you want to do stress echo, and if you want to follow them with frequent stress echoes to make sure they're asymptomatic, I think it could tailor the therapy and the surveillance a lot better that way.
Oh, absolutely. And I mean, we are talking about mitral regurgitation, right? But the same, perhaps even worse, would be for aortic regurgitation, because these patients go so far remodeled. I mean, these ventricles become like bovine hearts, right? I mean, it's a ventricle that will adapt to that. We underestimate great, by a great degree, by just the two-dimensional measurements, and that's where CMR needs to be in the forefront. And as Javier has very beautifully shown, it is an exam that, okay, if you don't want to do the gadolinium, you don't want to do the ECV, you could be a 30-minute exam or 30-minute exam, and you don't need gadolinium to do that, which, by the way, now should be given to everybody now, even in the GFR below 30. There's no signal of harm for these patients with the new generation macrocyclic agents.
And I think one last question, what are your thoughts on LGE versus high T1 mapping with intervention? Which one is going to reverse after therapy, and are your surgeons using it before surgeries to determine what they do?
Yeah, definitely LGE is a fibrotic scar that does not disappear. It will be there prior to and even after surgery. The plasticity of the changes in ECV is something that we're starting to learn with the aortic valve stenosis or pressure overload. That might have some plasticity because it's much more reactive. In this case, you're reactive to the volume overload, right? The ventricle is quite dilated, is already asking for help. That tends to improve after the correction of the mitral valve surgery, whereas the LGE is already further downstream.
Okay, thank you very much. That was an amazing lecture. For anyone that missed it, you can find it in YouTube, in our channel. And thank you very much for being here, and hopefully we'll see you soon.
Thanks again, Leandro, and the whole team there, Montefiore, for the opportunity.
Bye-bye.
Bye-bye.
Okay, bye-bye, Joao.